So I thought, talk on scientific truth, makes sense to really figure out, where do we come from? And this is a long time ago, 562 BC. It's kind of hard to even fathom that time. But this was the first clinical trial, as I could figure out, Nebuchadnezzar. And he ordered his warriors to eat a diet of meat and wine. And this is kind of hard to believe, but you'd think they were 2024. A couple of them complained and whined and said, we're vegetarians, we don't want to do that. And somehow he allowed them to do that. And so the ones that were allowed to eat vegetables and water for 10 days appeared to be better nourished than the meat eaters, and he allowed them to continue that diet. So you can imagine that as the first clinical trial. This is kind of another example, and I call it the first modern controlled clinical trial. This is James Lynn. He's known as the Hippocrates of naval medicine. He's from Scotland. He did his thesis on venereal disease, and I know Dr. Lumsden is from Scotland. I can never remember if he also did his thesis on that or not, but let's assume he didn't. But in 1747, this quote, I thought this was interesting and also relevant to the talk. He was interested in removing some of the rubbish that lies in the way of knowledge, and his treatise was upon attested facts and observations without suffering the illusions of theory to influence and pervert the judgment. So what's happening? We're using science to generate evidence that is hopefully true, based on knowledge and facts, but let's take a step back, and Best CLI basically said that surgery was better, very convincingly showed that. Basel II, very similar trial, a little bit different, I'll show you the differences later, had the exact opposite answer. So endo is better. So what's this about truth? Which one's right? Which one's true? So evidence-based medicine, you would think that's been around a long time, but it hasn't. It's actually been around since 1981, and a couple of guys in Canada, epidemiologists, kind of came up with the concept, and over time, we as a community kind of developed this pyramid of evidence, and randomized controlled trials sit at the top of it. Why is that? Well, there's nothing better than an RCT to eliminate confounding, which is bias, to minimize treatment selection bias, which is important, and can sabotage the entire effort, to reduce spurious causality, and it is the most reliable form of scientific evidence. It's got some problems. It takes forever. It is very expensive, and there's always questions about generalizability. But it's pretty good. So for anyone who doesn't know, it was the BEST trial was an NIH-funded RCT. It was pragmatic. That means we let people do whatever they wanted to do with regard to the treatment after randomization. We wanted to look at outcomes, quality of life, cost, and value in patients that were candidates for both. So that's the key metric. Not sure. This was the hypothesis. We broke it up into two cohorts. We thought that was important. Cohort 1, best case scenario, good single segment of saphenous vein. The hypothesis is that surgery would win. The second cohort was all the other, disadvantaged conduit, and the hypothesis was that endo would win. A novel endpoint. We did not use amputation-free survival. We thought it was a horrendous endpoint to study treatment strategies, and it was far too focused on death. I will get back to that, but this was our endpoint. Mayo, which is a major reintervention, new bypass graft, jump interposition graft, or thrombolysis. What it is not inclusive of is minor reinterventions, so a little touch-up in endo. That's part of the strategy. We didn't think it was fair to kind of bias the trial against that known kind of piece of the puzzle. Again, this is the result. And this is the primary outcome. So amputation-free survival, hazard ratio of 0.68 in favor of surgery. And that was driven by major reinterventions, and that was driven by amputations, both highly significant. Of note, it was not driven by death, and this is new and different. This is the Kaplan-Meier curve, relative risk reduction of 32%, number needed to treat of 10. This is major reintervention, again, number needed to treat of 7. This is amputations, again, significantly different. This is death, no different between two arms. This is MACE, no different between the two arms. And that's new, so no longer can you say, shouldn't do surgery because you're knocking them all off or they have all these heart attacks. And I do believe this data. There's plenty of other data to support this finding. So this is subgroup analysis. Nothing was significant, but everything kind of leaned towards surgery. This is cohort 2. Cohort 2 was so-called negative. There was no difference between the two. There was a significant difference in major reinterventions in favor of surgery, but the endpoint as a whole was not different. This is the primary endpoint, Kaplan-Meier. I'm not going to talk about quality of life except to say that these were the metrics we used, and this was a characteristic finding. So every metric at every time point, cohort 1, cohort 2, same finding. Early improvement, exactly the same for both endo and open. A little bit mysterious, again, the truth. Why did it not track with the clinical outcomes? We're looking at that data a little bit more closely to try to answer that question. What are the conclusions? Both are effective and both are safe. That can easily get lost in the messaging, but that's a very important finding. Patients who are candidates for limb salvage should undergo an evaluation of surgical risk, yes, and conduit availability, yes. Not everyone has to. You can decide whether they're a reasonable surgical candidate and then do it. So this created a lot of distress and, oh gee, I'm going to have to completely change my workflow. That's not necessarily the case. Bypass with vein should be offered as a first-line treatment for folks that are suitable candidates as part of a fully informed decision-making. Yes, level 1 evidence does not support endo first for all patients. It supports a complementary role for open and endo.